Thank you all for coming back for the second part of Public Square. And I'd like to start with Dr. Kaufman. We ended our last discussion talking about the importance of community health workers and the roles they can play in addressing some of these disparities. Could you talk a little bit more about that?
The health system only affects about 10% of what makes communities healthy. It's really the social determinants, education, diet, transportation, social marginalization, all of those other factors that are far more important in health. Community health workers spend much more time on the social determinants than we do, sitting in a clinic or in a hospital. So it's critical that we work in partnership with community health workers. One of the problems is that we've never been trained to work with community health workers, and many tell us, they'll bring patients to us, but we don't know how to work with them. Surprisingly enough, we just finished a study of 2,000 patients who just walked through our doors at the university and First Choice, and lo and behold, half of them had a major issue in social determinants. Number one was actually access to utilities. People wanted more education. They didn't have adequate jobs. Transportation was a problem, food access. It was totally unknown by the healthcare system unless these questions were asked. But when we got this answer, what do? So now the university has actually hired community health workers to match what we've heard around the table here to address these major problems.
Joaquin, I want to ask you, with that in mind, how is the university shifting how it trains doctors to encompass the realities we've heard in this room today?
There is a good amount in terms of trying to transform cultural competency within the curriculum of the medical school, from a standalone product to integrated within the whole sphere of it. And I think that's going to make a big difference. It takes a lot of time. And the reason that we saw that is the accreditation agency, LCME, for medical schools has actually prescribed that. And I think that is a huge policy issue that can change the way that medical schools approach this. And so further changes like that, I think, would help in terms of medical education. I think in terms of the other disciplines, they're in some ways a little bit further ahead, nursing and public health and other disciplines.
One thing I'd wonder is, would it help if we have 1 million Dr. Chacones? Of course, no. I mean, recruiting more Native and Latino Hispanic doctors to medical school.
One thing, I was just talking to Dr. Vallejos, who's the director of admissions at the medical school, and she was mentioning big effect that the BAMD program has had in terms of changing the demographics. And also Dr. Kaufman has noticed this, that since they focus 2/3 on rural communities and 1/3 on the urban, that we have seen a huge shift in the applicant pool. And so I think that's made a big difference. They apply out of high school, and they actually have a spot kind of reserved for them in medical school once they graduate.
I'm curious, I'm going to ask some of our folks who've been here what you think about these kinds of possible solutions that we're talking about, if that would address some of the issues that you are facing, right? Dr. Chacon.
Well, when you speak to our patients and our communities, if they had a choice, of course you want to have great communications with your doctor and trust with your doctor, no matter where you're at. And part of that trust is if the doctor looks like you. I am fortunate that I'm a Native physician working in a Native community, and I don't have to be a Navajo person working in a Navajo community for Native patients to tell me things that they otherwise might not tell, Dr. Kaufman, because he is not from the community. He doesn't understand that Native culture way of life that is just ingrained in who we are. And that's not to say Dr. Kaufman cannot, that there won't be a trust relationship there. There certainly would be. We need more Native physicians, Hispanic physicians, nurses, at all levels of the field of primary care and medicine. The other thing about having more diversity, more students coming into the programs at the university, is that the faculty and the staff have to reflect those populations as well, and the leadership levels.
Mm-hmm.
We are constantly sitting with families that their kids are interested in medical school. They're coming from the rural areas. They're not aware of resources. They're not even aware of the scholarships. Their want is there. And then they bring in right, other issues, especially in our more immigrant communities where they're carrying the family. So in some programs, they have actually put in financial packages like financial aid, not financial aid in the traditional of helping the student, but helping the family so that these students can get through college and go forward.
I think this is critically important because if you look at the social determinant that probably has the biggest impact on health, is just graduating from school. And if the attraction is to get into a health career, because it's a very big employer,
Right.
that's terrific. But just graduating from school means everything. So I think our investment in educational attainment is a huge benefit to health. And if we look at the populations in New Mexico who have the lowest rate of graduation from high school, it tends to be ethnic minority. It tends to be in rural areas. We don't invest enough in those, and we have to if we're really serious about health.
Absolutely, and we're moving toward those things, but you can't sacrifice the current generation of patients who need care now. And I think that's another thing that has to be done. The existing physicians, the existing medical students, regardless of what their backgrounds, have to be instructed in cultural competence, how to be sensitive to different cultures, because they're going to be providing care to different people as well. So it's absolutely crucial that we bring in the underrepresented groups to fill the healthcare positions. But they're not going to fill all of them. Everybody who's providing healthcare has to be culturally competent.
We had through the Center for Native American Health that incorporated something called a student navigator, where we have somebody from the institution kind of help navigate how to get through, but is it from the community, in the community, and kind of can help on both ends of it. So having somebody at the institution to help guide those kinds of hurdles and things that are there, but also learning what the resources and the obstacles that might be in the community and how to navigate through some of that. And so I think that's a really, it was a great model, and I think if we had more of those, but I think we see frequently that that kind of investment is difficult to encourage within the institution because you see it as, it's not, it doesn't generate clinical revenue, doesn't generate research money necessarily, and it doesn't quite fit into what the normal model of the institutional mission is.
Go ahead, Dr. Chacon.
When I went through medical school, I was one of the only few out of 300 students there. There were only 2 of us who were Native. Going through a cadaver lab, when it's taboo for me to be in a room with around dead bodies, basically, to be in that environment was just totally taboo for me, coming from the Navajo culture. To have to deal with that, there's nobody around at the medical school for me to have to be safe, to be in an environment, to talk to a faculty member, for them to understand what I was going through. That challenge, I mean, it still affects me today when I think about it. That diversity of teaching our students that come in, wherever they're from New York.
There you go again.
That having that diverse student population is that we teach each other, that we're in the same classroom, we're sitting side by side, we're at the same table, and that my perspective is heard and respected as much as I'm listening to his perspective.
Well,
as
I wanted to ask our health workers, because you seem to be key bridges, and I know Comadre does this as well, right? Sometimes you're going into the institutions with the patients and being bridges. How does that, is that effective, or are you respected in your role?
Sometimes, as far as going into an institution, we will also invite a family member, because the family member lives with the patient. But if some people that do live alone, yes, that's when we are there, and that's when we do the translation for a better understanding of their medical condition.
I've been there as a patient also, and I've been there as a peer navigator for Comadre. And the barriers are a lot. The language, sometimes me as patient, I have to wait hours for somebody to go into the room and translate for me, because even when I speak English, just the fact that they speak to me in my own language, that is what I want. I want the trust there. It doesn't mean that I don't trust the other people, but I feel more comfortable listening to a doctor that is telling me something and I'm going to understand 100%.
I've had the opportunity just recently where I was with a patient and she went to go see her oncologist, so the oncologist happened to have a Spanish-speaking physician with her. I mean, beautiful Spanish. And I saw the difference after the appointment with the patient, how she felt more comfortable, understood everything that was being said to her, and you could tell in the face that she walked out with a lot more information that she understood in her language versus when there isn't someone to interpret for her. They can have the interpreter, yes, but the actual person being a physician was a much more effective visit with the doctor at that point.
Another thing is a lot of the Native people won't take the time to read what the physicians give them. So a lot of us, when we're doing the health education, we use a visual because we intake that information better if we see visuals.
Emily wanted to say something.
There's a big drive for culturally congruent or culturally competent care that is being taught at the university level or at the academic level. And what we see in practice is very different from what they're saying is being taught. So we've seen some good examples of what should be happening, having an actual a Spanish-speaking physician. That's a great example. But what we see in the textbooks is stuff like Native people don't like to make eye contact. That's a classic example of what we see in the nursing texts. So, or I see, I go on a tour of a floor with a nurse and they'll say, we're practicing culturally congruent care. We have very large rooms, so when our Native patients come and they have all their family here, we can fit them all in the room. Well, that's nice, but who are you talking to when you have this family? That's just the first step. And so the way that the CHRs are really helping out is they're helping direct the care here. They're helping to slow down the conversation so that when the clinician walks into the room, the conversation doesn't take place in 3 seconds and then they're out of there. They're saying, whoa, 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 no, you need to slow down and you need to have this conversation at our pace.
Dr. Kaufman.
A lot of the interventions with community health workers are in the comfort zone of the clinicians. It's our turf, it's our hierarchy. We move in and out at our pace. But we've begun to see that there are community health workers who actually run clinics and they supervise where we are outside our comfort zone. And one of the best examples that we've learned the most from is in the international district, and it's specifically for undocumented immigrants. The one population that's not going to receive any benefit from the Affordable Care Act, but they're a vital part of our community. No patient leaves that clinic unless they go through an exit interview with the community health worker. Over half the patients, the community health worker comes back and says they didn't understand what you said. They can't afford the medicines you prescribed. You sent them to a place that has no interpreters. Could you change this? Or worse, which is more embarrassing, you didn't understand what the real problem is. Because that trust as part of an exit interview was critical. So we're scratching our heads and thinking, wait a minute, half the patients in our regular clinic at the university probably don't understand what we're saying, and they're just nodding. So we do have to change the location of where we practice and learn to really respect what this powerful role of a community health worker
You mean the
is.
physical location?
Absolutely.
It would be wonderful to change those power relations
Exactly.
where the community health workers, the promotoras, the navigators are a critical part included in the team. They're not just, you know, well, let's get that CHR or promotora to find that woman that can't come to the biopsy. But how about not the afterthought? How about at the front and center?
Exactly.
And I think that that's where I see a challenge with us, is that we see that there isn't that desire to invest.
But then the doctor-patient connection needs to be there too. They come in with a clipboard and say, okay, Ms. Burt, your hemoglobin, your this and that, your vitamins, your calcium, and they know they're okay. And one time I just sat there like this. I put my hand on it. And she didn't even, like, the door opened this way, and I was sitting there. And the counter was right there. She laid her book on it and read it. Then
She didn't look at you.
Then silence. She turned around. I said, "Good morning, doctor." And then I, you know, I told him that I was just waiting for you to start talking to me. You're standing there talking to the clipboard, I said.
Yeah.
Dr. Espy, there's some doctors don't react well when patients, speak up.
They don't. They don't. You know, they don't.
I just,
You know them. They
is
don't.
there anything? How do you achieve? We're talking about a lot of cultural shifts here.
It is critical to elevate the role of community health workers and CHRs and the clinical setting. But I think there's an enormous opportunity, especially in cancer prevention. A third of cancers, roughly, are due to inadequate physical activity, obesity, and poor diet. And there's an enormous opportunity for prevention where the community health worker, CHR profession can really have a huge impact.
You know, a lot of these things not only can the CHRs address, but if we stand in solidarity between sectors like education and health and policymakers, law, to talk about the basics, you know, the stress that's created because a parent can't have a job that allows them to pay for healthy food, or to, you know, they have to work 3 jobs to just make ends meet, to make the rent payment, to make the utilities. Those things have the greater effect on the stress levels, which also affect how your body deals with illness.
Dr. Chacon, you could see a patient and recommend, you need to eat 5 to 7 fruits and vegetables a day and go out and exercise. And what do you do when that's not a reality that they can meet necessarily if they are facing some of those?
I think it really takes a great understanding from the provider level, what is available and what isn't, what's realistic. I can tell them everything about how to live and eat more healthy, but unless we can address some of these other issues, these social determinants, then, I've spent all my time talking and doing all of these things so then I will address what else is going on. What are the stressors in your life? What is preventing you from doing some of these things? How do we help, and facilitate getting someone healthy?
We started a men's and women's group. Some of the things that the health workers talked about was we're forgetting on how when our elders grew up, they were healthy, diabetes was not around, cancer was not around. What did they do then versus what we have now? So I know in the men's group, I'm just gonna share a little bit of what they were talking about is they're gonna go back in traditional planting. Hunting, they hunted for their food, they walked to go get their water. So they're doing the education from young kids to elders. So in their group, they have a variety of people that are participating. So, if we go back to how we lived before, I think it should make a difference, and it'll be better, a little bit better. Better understanding of where we are at now that we have all these Cheetos and sodas and not exercising.
Going back to the comment that Dr. Chacon was making about telling these people eat healthy food and stuff, that's a huge barrier. But imagine the barrier now with this new law that they want to implement, taking away the driver license from the undocumented people.
Mm-hmm.
What our ladies are going to do, what they are going to do when they have to go for chemotherapy, how they are going to drive if they don't have driver license. Who is going to drive then? The husband probably is undocumented too, and he can't drive either. So if they don't have driver license, how they are going to save their life? So I was thinking that before taking all these huge decision, they need to see that we are human beings,
Well, when I first got diagnosed in surgery, I was bombarded with information. I didn't know I had a navigator. I didn't know I had a case manager. So family members or CHR to go with you, because you're bombarded with all kinds of. I made so many mistakes. I made wrong choices. So that's what I want to do. Educate people. You have choices, and ask the doctor.
What would be the most effective solutions that we could implement now?
If a group of people will put together a binder and list all the resources, we try to look for resources so we can refer people to pick up a box of groceries, or we help our women with gas cards for them to be able to go to their appointments. So I personally think, had I been given a binder telling me this, you could do this, you could do that, I think it would have given me a better idea as to what I could do and what was out there in the community to help me to focus on my health.
It does seem like community health workers they are already acting as sort of that kind of role, the way you described in the clinic here, Dr. Kaufman. So is it a matter of integrating them more into the health system?
I think one of the advantages now is that there's a payment source that we never had before. For those who are on Medicaid, now the way managed care companies make their money is to keep people healthy. Well, what a concept. That's why they are investing in community health workers, social determinants. It's the kind of change and incentive that we never had before. Because if we did things in prevention, we didn't get paid for it. Now they have to invest in it. So I think if we have to look at different strategies where you have kind of the wind at your sails, some of the big funders now can support this where they never did before.
Is this because of the Affordable Care Act?
Because of the Affordable Care Act.
We brought this up like 20 years ago, but we were shoved to the side. What we were told is, you know, the professional, the doctors, the nurses, the LPNs, the pharmacists, all those are licensure. That was a blow below the belt with our, you know, CHW, CHRs, and promotoras, because they said they're not licensed, they're not professionals. Well, to heck with you, you know? We're the ones that you're gonna come full circle.
Well, you were on the forefront long before public policy caught up with you. I want to thank you. I'm going to give Carmen Gloria, do you have a final word before we leave?
I believe that everybody, it doesn't matter where they're coming from, they need to be treated with respect. They need to be treated with dignity. We need the right to communication with our doctors and our healthcare system. We need partnership. We need help. So I've been there, and it's really hard. So I hope everybody can open their heart and say, these people really need help. Not only to get better physically, but also psychologically. Because when cancer comes, it doesn't come, it's just not only the person that gets the sickness, it's the entire family. And we are there, and we need you guys. Thank you.
Thank you very much. I appreciate you all coming to talk about this.